Hello everyone, this is Dr. Garima Sachdeva and today we'll be discussing about the ectopic pregnancy. We will be discussing about the various types of ectopic pregnancy, how do you diagnose it, what is the management, what is the preferred management and the various other management choices and what should be the further follow-up. So stay tuned, hope you find it useful.
There are two guidelines. One is GTG and one there is a talk on cesarean scar ectopic pregnancy. Both of these will be covered. So what is ectopic pregnancy? Ectopic pregnancy is any pregnancy which is implanted outside the endometrial cavity. Incidence is around 2 to 3% and in UK it is approximately 11 to 1,000 pregnancies. Then what are the risk factors? So what are the risk factors for ectopic pregnancy? So anything which causes damage to the tube can result in ectopic pregnancy. So if there is, it could be because of surgery, because the most common is the tube ectopic. So that's why. The other thing is if there is infection, if the patient is smoking, it damages the collagen fibers. Post IVF, because if the embryo is implanted little up, like if it's inserted little up during the embryo transfer, it increases the risk of ectopic. In about 1/3, this question you get, there is no identifiable risk factor for ectopic pregnancy. Is it better? The voice is better now?
Yes, ma'am, it's better.
Okay. So diagnosis, if they ask you which is the investigation of choice for ectopic pregnancy, it's a transvaginal scan. Okay. And there is no rule of other things like progesterone. Beta HCG is important not for the diagnosis but for planning the management, because it depends on the drop of the beta HCG and the initial levels which determine the treatment. So this I'll be discussing in later slides also. So beta HCG is not per se for diagnosis. It is more important in planning the management. Okay. And nowadays, because of improving, we have 3D ultrasound and all that, improving ultrasound resolution, laparoscopic is no longer considered a gold standard. So they ask what is the investigation of choice or gold standard for diagnosis of ectopic pregnancy. In general, your answer will be transvaginal scan. Okay. And adnexal mass, which is moving separate to the ovary, because it is in the tube. So when you insert a probe in one of the corners where there is ovary and the tube, so you will be able to see a mass in the tube which is separate. You'll be able to see the ovary separate and the tube separate. And when you move the probe, both of them move separately. So that is called as a sliding sign. It comprising a gestational sac containing a yolk sac or an adnexal mass moving separate to the ovary, comprising a gestational sac and fetal probe with or without heart. Okay. So TBS, as I've told, is the investigation of choice. So what all findings you get on TBS? So you will find an inhomogeneous or non-cystic adnexal mass, which is the most common finding. So they ask you what is the most common finding for ectopic when you're doing a TBS. So it is basically a mass which is seen separate to the ovary with a positive sliding sign. An empty extrauterine G-sac can also be present in around 20 to 40% of the cases, while an extrauterine gestation sac containing a yolk sac and or embryonic pole that may or may not have cardiac activity will be present in around 15 to 20% of the cases. Okay, so you may see an extrauterine sac with or without embryonic pole, with or without cardiac activity, which will be present only in 50%. Then in up to 20% of the cases, you see some fluid collection in the cavity, which looks like a pseudosac. I'll be showing the picture of this in the subsequent slide. And sometimes it's ecogenic fluid. If it's a rupture ectopic, that fluid collection in the POD that you see, which is seen in 28 to 56% of the cases. So this is how you differentiate on scan ectopic pregnancy and intrauterine pregnancy. So intrauterine pregnancy, you see a double decidual sign. So there are two rings, okay, double ring sign. So there is a fluid collection surrounded by two concentric rings. However, in pseudo G-sac, which is also known as intradecidual sign, you just see some fluid collection and there is no you cannot see this demarcation of two concentric rings around. So there is a thin endometrial lining which is around. So this is known as pseudo G-sac, which can be seen in ectopic pregnancy. This is a true G-sac where you see a proper decidual reaction. There are two concentric rings. There is a ring outside because there is decidua and the chorionic villi. So you see a double two concentric echogenic rings in cases of true G-sac. Then this was about the tubal ectopic. Now coming over to cervical ectopic. So this is the uterus, this is the bladder, this is the cervix. So in the cervix, you see that the os is closed. However, you are seeing a sac with or without a fetal pole implanted in the cervix, and the uterine cavity is empty. So this is how it appears. Okay. So cervical ectopic, it is quite rare. It is less than 1%, seen in less than 1% of ectopic pregnancy. The ultrasound features have already told there is empty cavity, barrel-shaped cervix. So cervix is dilated. So you see a uterus and then you see a cervix, the dilatation of the cervix. So it appears like a barrel-shaped cervix. Gestational sac, please mute. All of you, please mute yourself. Yeah. Then gestational sac, which is present below the level of the internal os, and there is absence of sliding sign. So what happens? Sometimes in miscarriage also, if it's an impending miscarriage, you will see the products in the cervix. So how will you differentiate between the cervical ectopic and abortion? So it is because of this absence of sliding sign. So what happens when the pressure is applied to the cervix using a probe in a miscarriage, the gestational sac slides because it is not implanted properly. It slides against the endocervical canal, but it does not in case of implanted cervical pregnancy. So in tubal ectopic, you see a positive sliding sign. In cervical ectopic, you see a negative sliding sign. Okay. And then obviously you see when you put the blood flow, because if it's implanted, there will be increased blood flow around the sac. So if you put a Doppler, you will see blood flow around the G-sac using color Doppler. Then what about the biochemical investigations? So single serum beta HCG should be carried out at the time of ultrasound diagnosis of ectopic. If the beta HCG levels are very high, it is more than 10,000, it is associated with decreased chance of successful medical management with methotrexate. So in these cases, if the beta HCG levels are very high, you'll have to operate these patients. Okay. Then this was about the cervical ectopic. Then there is cesarean scar ectopic pregnancy. So it is diagnosed by ultrasound and MRI. So they ask you this question in which, because sometimes you cannot see a well demarcated thing in cases of these cesarean scar ectopic. So you're not able to differentiate with a vaginal scan alone. So this has to be supplemented with MRI. So they also ask you this question that what other kind of pregnancies you use MRI to support the diagnosis. So for ectopic. So it is if it is an abdominal pregnancy or if it's an interstitial pregnancy. So these are the three pregnancies, ectopic pregnancies, where you need the help of both ultrasound and MRI to come to a conclusive diagnosis of the type of ectopic pregnancy, cesarean scar, abdominal, and interstitial pregnancy. Okay, so in a cesarean scar ectopic, what all findings do you see? So you see the cavity is empty. However, you'll see the lining in the cavity. However, gestational sac or a solid mass of protoplastic tissue is located anteriorly at the level of the internal os, embedded at the site of the previous lower uterine segment cesarean. So where like you give the cesarean scar in the lower segment, usually where the intrauterine pregnancy is usually in the upper part. Okay, but in this case, where there is cesarean scar pregnancy, it is implanted at much lower, okay, part of the uterus. So it is implanted at the site of the previous scar where you had given, which you had given for the previous cesarean section. You see a thin or absent layer of myometrium between the gestational sac and the bladder, because sometimes what happens, it perforates out of the uterus, the wall, and reaches the bladder. So this can also happen, and it is in the myometrium, which is quite close to the bladder. So you see a very thin myometrium above it. Usually you see a good chunk of myometrium between the bladder and the gestation sac. However, in this case, you will see a very thin layer of myometrium. Then evidence of prominent trophoblastic or placental circulation on Doppler. So wherever there is ectopic, you will see more blood flow. And in this, both cervical and the uterine cavity both will be empty. Okay, so cesarean scar pregnancy, it is defined as implantation into the myometrial defect at the site of previous uterine incision, and it is quite, the prevalence is quite low. It is 1 in 2000 pregnancies. Then interstitial ectopic pregnancy. So in this, what happens? The sac is implanted into the interstitial portion of the fallopian tube. Okay, and it is seen. So this is the uterine cavity. This is the interstitial portion of the fallopian tube where the sac is implanted. So for this, the incidence varies between 1 and 6.3% of the pregnancies. And the interstitial part of the fallopian tube is about 1 to 2 centimeter in length, and it traverses the muscular myometrium of the uterine wall, opening via a tubal ostium into the cavity. So it is just adjacent to the ostium. So it is not, the sac is not implanted in the cavity, rather it is implanted in the interstitial part of the fallopian tube. So again, for this also you need MRI to supplement the diagnosis. And there is this sign which you get in question, what is interstitial line sign, and in which kind of ectopic pregnancy you see it. So interstitial line sign is when a thin echogenic line is seen extending from the central, this is the uterine cavity. If you draw a line from the uterine cavity to the periphery of the interstitial sac, you can see there is a thin line joining it. So this is what the interstitial sac sign is. Okay, in this also the uterine cavity will be empty, and the products of conception or the gestation sac are located laterally into the interstitial or intramural part of the tube, surrounded by less than 5 mm of the myometrium, because obviously it's in the tube, so it will not be surrounded by much of the, only in the medial portion little bit of myometrium will be surrounding the sac. So this the question you get, what is interstitial line sign and in which kind of ectopic pregnancy do you see?
Ma'am, how to differentiate this from cervical?
No, this is in cervical, as in the cervical canal. This is in the fallopian tube, interstitial part of the fallopian tube. So in this, the cervical canal will be empty. It is just at the upper portion of the tube at one of the sides. Okay.
Okay.
Then there is something called as cornual ectopic pregnancy. It is this question you get, what is the rarest form of ectopic pregnancy? So it is a cornual pregnancy, which is the rarest, with an incidence of 1 in 76,000 pregnancy. And for this, investigation of choice is transvaginal scan. In this, you see a single interstitial portion of the fallopian tube in the main uterine body. So it is primarily seen in unicornuate uterus. So where you have just one cornua, where the where the pregnancy is implanted, you are not able to see the other cornua. So it is primarily in the unicornuate uterus. So gestation sac or products of conception are seen mobile, separate from the uterus and completely surrounded by the myometrium, and vascular pedicle adjoining the gestational sac to the unicornuate uterus is seen. So this is cornual pregnancy. Then coming over to this ovarian ectopic. So for ovarian ectopic, transvaginal scan is not the diagnostic investigation of choice. This is the only ectopic where you have to confirm the diagnosis using laparoscopy. Okay. So if they ask you for this thing, for ovarian ectopic, what is the investigation of choice? So if you will be seeing the recalls, you will get this question. So it is for the ovarian ectopic, the investigation of choice is laparoscopy. And TBS, there is no specific agreed criteria for ultrasound diagnosis of ovarian ectopic pregnancy. In this, you will see an empty uterus with a wide echogenic ring with an internal anechoic area on the ovary. It is not possible to separate the cystic structure or gestation sac from the ovary, because obviously it is in the ovary on gentle palpation. So there is negative sliding organ sign. So if you slide, like unlike in tubal ectopic where you were sliding the ovary, it was sliding separate to the ectopic sac, right? In this case, both of them will slide together. So it is negative sliding sign. Understood?
Yes, ma'am.
So it is the only ectopic which is diagnosed laparoscopically. Diagnosis is usually confirmed surgically and histologically, as it can be difficult to distinguish ovarian ectopic pregnancy from corpus luteal cyst or tubal ectopic pregnancy stuck to the ovary, a second corpus luteum, or ovarian germ cell tumors and other pathologies. So you should use laparoscopy to confirm the diagnosis. Okay. Then about abdominal ectopic. So again, for abdominal ectopic, you need MRI as a support to diagnose. And in this, the sac is implanted in the abdominal cavity. So uterine cavity will be empty. You'll see absence of both an evident dilated tube and a complex adnexal mass because it's in the abdomen. It is not in the tube or the ovary. A gestational cavity surrounded by loops of bowel. So you'll see a sac which is surrounded by the loops of bowel and separate from them by peritoneum. Okay, so sac is amongst the loops of the bowel. A wide mobility similar to fluctuation of the sac particularly evident with pressure on the transvaginal flow. So it will be because there is a free space in the abdominal cavity. So it will be moving. You'll see a lot of mobility in the sac. Okay, if you give the pressure on the transvaginal probe towards the posterior cul-de-sac. Then there can be heterotopic ectopic pregnancy. So what is heterotopic? It is again in this there is a sac in the uterine cavity and there is one sac located outside. So it is again diagnosed by ultrasound. In this, beta HCG have a limited value. Heterotopic pregnancies should be considered in all women presenting after assisted reproductive technologies in women with an intrauterine pregnancy complaining of persistent pelvic pain, and in those with persistently raised beta HCG levels following miscarriage or termination of pregnancy. So these are the conditions where heterotopic pregnancies are seen. Now, how do you manage these kind of ectopic pregnancies? So there are three modalities of treatment. One is the expectant management, the other is medical, and the third one is surgical. So how do you decide whether you have to go for expectant or medical or surgical? So there have been set criteria for the to help in deciding. So expectant you go for if the patient is clinically stable and the patient does not have any pain, if she's pain free, or if they have a tubal ectopic pregnancy which is less than 35 with no visible heartbeat on transvaginal scan, or the HCG levels are less than 1000, or those patients who are able to, because in this you have to monitor the beta HCG levels that it drops. So they should be able to return for follow-up for the beta HCG levels, and the success rate is variable between 57 to 100%. Then how do you follow up these patients post-expectant management? So you have to, one, on admission you'll do a beta HCG, then you have to repeat the beta HCG on days 2, 4 and 7. Okay, if between day 2, 4 and 7 the drop is 15% or more, then you do it weekly beta HCG until it comes out to be negative. Okay, understood. This is important. So how do you follow up these expectant for expectant management? How do you follow? You do beta HCG levels on, like you've left the patient, you've done on the baseline, then again on day 2, 4 and 7 you do, and you find out how much is the difference between day 2 to 4 and 4 to 7. If the difference is more than 15%, that's good enough difference. That means it's falling properly. Then you do it on weekly basis until it turns out to be negative. And what is negative? Negative is when beta HCG levels are less than 20. Okay. Or if the beta HCG levels, they do not fall by 15% or stay the same or rise from the previous value, then what should you do? Then you should review the women's clinical condition and seek senior advice to help decide further management. Okay, so this they ask you, like if it doesn't fall properly, then what should you do? So if it doesn't fall by more than 15%, then you should seek a senior advice. Then this was about management. Now coming over to medical management. So medical management we offer to patients who do not have any significant pain, or if the it is an unruptured tubal ectopic and with a sac size less than 35 mm and there is no visible heartbeat. The HCG level previously we said it was for expectant it should be less than 1000. For medical it should be less than 1500. And who do not have an intrauterine pregnancy and are able to follow up. They should also be again able to follow up. So how do you go about the medical treatment? So medical treatment on day one, like once you've decided the patient fits in the criteria of medical management, then how do you go about? So like on day one, you have to do some blood test. Okay, so if these reports are normal, you have to do a beta HCG because you have to see how much does it fall. You have to see, do this urea and electrolytes of 2 LFTs, fasting full blood count, blood group. So all these blood group to decide for antigen. So all these, if these reports come out to be normal, then you give them 50 mg per meter square intramuscular methotrexate. So they ask you what drug do you use for medical management of ectopic. So you use methotrexate. And what is the dose? It is 50 mg per meter square. Then you repeat again. You repeat beta HCG on day 4 and 7. And if you see that the decrease in the levels is less than 15% between 4 and 7, then you give you compare like from day 4 to day 7 how much is the fall. Then if you feel that it is less than 15%, then you repeat give a second dose of beta HCG, and it is the same dose 50 mg per meter square if she still fulfills the criteria for medical management. If beta HCG decreases to more than 15%, this 15% value is important. So if the decrease is more than 15% and between days 4 and 7, then what you do, then you just keep on following the patient on weekly basis until the beta HCG levels becomes negative. And here they have put the criteria as 15. Okay, so until it becomes less than 15, you keep on doing beta HCG on every weekly basis. Then what are the precautions that you should you carry out while you are managing the patient of ectopic, giving methotrexate and medically managing the patient? So during treatment with methotrexate, females should be advised to avoid alcohol and folate containing vitamins. Why? Because methotrexate is folate antagonist. So if you give this folic acid, so that its function will be reversed, like it will not be able to act. So they should avoid alcohol and folic acid. Alcohol is an enzyme inducer, so it cause like it will affect the function of methotrexate. So they should avoid alcohol and folate containing vitamins. And what are the adverse reactions that you should be like guide the patient? So what all methotrexate, because it's an anti-tumor agent, so it causes it can cause marrow suppression. It can result in pulmonary fibrosis, can result in non-specific pneumonitis, liver cirrhosis, renal failure, and gastric ulceration. So these are the side effects of methotrexate. And they ask you what is the most common side effect. So this is one of the questions which is in your recalls. So what is the most common side effect? All these are side effects, but what is the most common side effect? The most common side effect is excessive flatulence and bloating due to interstitial gas formation. So this is and a transient mild elevation of liver enzymes and stomatitis. So these are the most common side effects. Okay, and these are the most severe side effects. Then what are the contraindications when you should not go for methotrexate at all? So contraindication if the patient is hemodynamically unstable. Then in those cases you will directly go for surgical management. Or if there is a presence of intrauterine pregnancy, okay, there is an existing intrauterine pregnancy. If you give methotrexate, it will damage the intrauterine pregnancy also. So in that case, you prefer to give you can give KCL. In that case, you can locally inject KCL into another sac. So that's what you can do. Then if the patient is breastfeeding, again you cannot give methotrexate because it is excreted in breast milk. If the patient is unable to comply to the follow-up, because it's very strict follow-up is required for medical management. You have to follow them.
In that case, so we give KCL only if in case of breastfeeding.
Sorry?
No. When a female is breastfeeding, do we give KCL only at that time?
No. Only in this case when there is an existing, it's a heterotopic pregnancy where there is a sac in the uterus and there is a ectopic sac. So in that
Okay.
case, if
If
you give
she is breastfeeding,
methotrexate, if she's breastfeeding, then you should not give methotrexate. You should do surgery rather.
okay, surgery. Okay.
Or if beta HCG level is very low, you can just follow up.
Okay. So
Because
medical management is not applicable. Okay.
yes. If the patient is unable to comply to follow up, if there is a known sensitivity to methotrexate, if there is chronic liver disease because methotrexate causes liver cirrhosis, or if there is blood dysplasia because it causes this severe pancytopenia, or active pulmonary disease because it causes pulmonary fibrosis, or if there is immunodeficiency previous because it's again an immunosuppressant, or if there is a peptic ulcer disease because again there is risk of excessive bleeding in that case. Then this was about the medical management. Now coming over to surgical management. So what are the indications of going for a surgical management? If there is an ectopic pregnancy and the patient is complaining of excessive pain, so then you should think about rupture. Okay. So in those cases, you should go for surgical management. Or if the sac is more than 35 mm, or there is a visible fetal heart rate, because then the risk of failure of medical management is more. Or the HCG levels are very high, like if it's more than 5,000. So between 1500, I said, like for the expected management, it should be less than 1,000. For the medical management, it should be less than 1500 ideally. And for surgical management, if it is more than 5,000. So between 1500 and 5,000 is the dicey zone where you have to use your clinical judgment and decide what you have to go for. Then about the surgical management. So there are two options for surgical management. Either you can do salpingectomy or salpingotomy. So salpingectomy is when you remove the entire tube. And salpingotomy is you create a hole in the tube, you remove the products, and then you suture it again. So that is salpingotomy. Or okay, so these are the two things that you can do. And how do you decide whether you should go for salpingectomy or salpingotomy? So if the previous tube, like if the other tube is healthy, then you should always prefer salpingectomy because there is always high risk of recurrence in that tube. So if one tube is healthy, if you get a like question in a question, the patient has ectopic, and the tube, the other, this is the first ectopic, and other tube is healthy, then you straight away remove that tube. You do salpingectomy, and then how do you follow up these patients? You follow them because once you have removed the tube itself, the sac, you need not do a repeated beta HCG levels in these cases. Okay, so you can just do a urine pregnancy test after 3 weeks. Okay, in these cases, the risk of repeat ectopic is 5%, and persistent trophoblast, like some tissue remaining, trophoblastic tissue remaining, the risk is 1%. The other thing is salpingotomy. So when do you decide for
in case of
salpingotomy?
salpingotomy, will there be defect in motility of the tube later?
Yeah, but you cannot, like you cannot do anything because you do it only in those
No other
conditions where there has been previous ectopic. You cannot remove both the tubes. Okay.
So
If there
we
has
are
been previous this you go for. That's why you always prefer salpingectomy unless you go for salpingotomy only if the other tube is unhealthy. When will the other tube be unhealthy? If there has been a previous ectopic where you had removed the previous tube, or there is contralateral tubal damage, or there is previous abdominal surgery or previous PID. So these cases where the other tube is also damaged, you cannot remove the tube. So in those cases, you do salpingotomy. So this is one of the very important recall questions which they ask when you go for salpingectomy and salpingotomy. And in this case, when you do salpingotomy, there is 1 in 5 they need further treatment like methotrexate or salpingectomy because of the repeat ectopic or persistent trophoblast. And how do you manage in this? Because you're not removing the tube. You're just opening and clearing the contents. So in this case, you have to repeat the beta HCG after 7 days and then repeat it weekly until it turns out to be negative. And in this, the risk of repeat ectopic is very high, around 8%, and persistent trophoblast it's around 3.9 to 11%. And the factors that have suggested that as increasing the risk of developing persistent trophoblast include if there was a previously high beta HCG level, if there was rapid preoperative rise in the beta HCG level, or the tubal mass was very big. So in these cases, the risk of persistent trophoblastic tissue is much more. Then whether you should give anti-D or not. So like according to the national protocol, you have to give anti-D to all Rh negative women who receive surgical removal of the ectopic, or where the bleeding is repeated, heavy, or associated with abdominal pain. So in these cases, you have to give anti-D. Then like post ectopic, because you have to monitor the beta HCG level that it comes back to the baseline levels. So you should advise the patient that she should not conceive for 3 months. Okay, and after 3 months she can conceive. So this was about the tubal ectopic majorly. Now coming up to the management of other forms of ectopic. So the first one is abdominal ectopic. So for abdominal ectopic, you have to do a laparoscopic removal is an option if it's an early abdominal pregnancy. Possible alternative treatment include systemic methotrexate with ultrasound guided fetocide. Advanced abdominal pregnancy should be managed by laparotomy. Avoid it, like if it's like big fetus, like sometimes this abdominal pregnancy, there are case reports which show they have exceeded till term as well. So in those cases, you cannot do laparoscopic removal. In that case, you have to do laparotomy. And in these cases, you should avoid incising the placenta because then the bleeding can be huge, massive. And the placenta maybe because it is implanted to the adjacent organs like bowel and all that. So you should try leaving the placenta in situ if the vascular attachment involves major vessels or vital structures like bowel or bladder, and spontaneous resorption is awaited. So it gets spontaneously resolved. Then preserving the placenta or its retention is associated with, you should counsel the patient like when you are leaving the placenta, why you are leaving it, because you don't want massive hemorrhage. But like when you are leaving that placental tissue inside, there is again a risk of ileus, because if it's implanted in the bowel, or bowel obstruction, or a fistula formation, or hemorrhage, or peritonitis. So these consent you should take from the patient. And you can give adjuvant treatments like methotrexate or selective arterial embolization, like the vessel which is supplying the placenta, you can embolize that, so that way it gets shed off. So that you can do. So this was about the management of abdominal pregnancy. Then ovarian ectopic. So for ovarian ectopic, if they ask you how to manage it, so for its diagnosis as well as treatment, the gold standard is laparoscopy. Surgery is the standard treatment. So definitive surgical treatment is preferred if laparoscopy is required to make the diagnosis of ovarian ectopic. So when you're doing laparoscopy to identify ovarian ectopic, that time only you should remove it. Systemic methotrexate, it can be used to treat ovarian ectopic pregnancy when the risk of surgery is high or post-operatively in the presence of persistent residual trophoblast or persistently high beta HCG level. So even after you have removed, if the beta HCG levels continue to be high, or if there is persistent trophoblastic tissue, then you can give a systemic methotrexate as an adjunct to the surgery. But standard treatment, if they ask you for ovarian ectopic, it is surgery or laparoscopy. Then coming over to management of cornual pregnancy. So for cornual pregnancy, where it is it is implanted, the sac is implanted in the cornua, again, there is no option of medical management because that space is very narrow. If you give medical management, because of the bleeding, it can rupture. So in this also, you have to excise the rudimentary horn. Usually in this, it is in one of the rudimentary horn. So you have to excise, and there is chances of recurrence also. So you have to excise the rudimentary horn via laparoscopy or laparotomy. There is no role of medical management. And the laparoscopic technique is safe, but attention needs to be paid to the possibility of urinary, because if it's a unicornuate uterus, then there can be risks of like associated urinary tract anomalies as well in 30% of the cases. So these things should be kept in mind when you are giving the incision, like for when you are.
Ma'am, when we give incision, then what happens to the tube?
No, you have to remove, like for this you have to, it is not in the tube. So it is basically uniconnuate uterus. So uniconnuate uterus is nothing there
So
is
it will happen in uniconvate uterus only.
a rudimentary horn. So the implantation is in that rudimentary horn. Okay, so you just remove the rudimentary horn. So one horn with the tube is removed because anyways it is rudimentary horn where there is no connection.
Okay.
Okay. Then about interstitial pregnancy. For interstitial pregnancy, expected management is suitable only for women with low or significantly falling beta HCG levels, in whom the addition of methotrexate may improve the outcome. Okay, pharmacological approach you can use using methotrexate has been shown to be effective, although there is insufficient evidence to recommend local or systemic approach. Surgical management by laparoscopic cornual resection or salpingotomy is also an effective treatment. So you can do anything for interstitial. You can think of, like, if it's a polybeta HCG, you can think of expected management. You can try methotrexate. If again the beta HCG levels are low, or you can, if it's high, patient is unstable, you can also go for surgery. So all three options are available. Alternative surgical technique, because it's in the interstitial portion, you can be using a hysteroscopic resection under laparoscopic or ultrasound guidance can also be done. So you put a hysteroscope inside and reach the interstitial portion and you remove the contents. So that also can be done. Then coming over to cesarean scar ectopic. So cesarean scar ectopic also, the preferred management option is surgical as compared to medical. Okay, because why? Because in this case, it is implanted at the site of the scar site, which is very deep, and there is risk of uterine rupture and perforation. So always surgical management and excessive bleeding. So always surgical management is preferred because there is a severe maternal morbidity and mortality. Disadvantage of using medical management like methotrexate, either by local injection into the sac or giving systemically, is that trophoblast remains in situ and there is risk of excessive hemorrhage as retained, often very vascular placental tissue degenerates. So they can be later on, they can be excessive bleeding. So that's why you don't go for medical management. Always surgical management is preferred. Surgical management, it consists of either evacuation of the pregnancy using suction or hysteroscopic resection, or excision of the pregnancy as in open laparoscopic or transvaginal procedure. So you can just, using suction or hysteroscopically, you can just remove those products. Suction evacuation is probably the most frequently described procedure and has been combined with cervical cerclage, because it is like the lower portion of the uterus becomes weak, so it is usually combined with cervical cerclage, Foley's catheter inserted, or uterine artery embolization, because there is a risk of excessive bleeding in the later on period. So usually you combine with these modalities, like you put a Foley's catheter so that it can provide a tamponade effect and help control the bleeding. Or what you do, you can do send the patient to interventional radiology and they will embolize the uterine artery. So that is where the blood supply to through the cesarean scar pregnancy is getting. So once you embolize it, the blood supply is compromised and the risk of bleeding is less. Then for cervical pregnancy, medical management is preferred over surgical. Medical management, how do? You give methotrexate because it is lower. It can be considered for pregnancy, but is less than 12 weeks if there is absence of fecal cardiac activity or lower serum HCG levels and are associated with more successful conservative management. Surgical options, they have high failure rate and should be reserved for those females who are suffering from life-threatening bleeding. What are the options which are available in terms of surgery? Dilatation and curettage, hysteroscopic resection of the pregnancy, or uterine artery embolization, or hysterectomy if there is uncontrolled bleeding. So for cervical pregnancy, you should remember medical management is always preferred than surgical. So this was all about ectopic pregnancy and the management.